during these video sessions, you appreciate that it's easier perhaps to see these specimens in pseudo 3 dimensions, and you'll take the opportunity, as I say, to look at them yourself next door. As Prof said, the problem is really that over the years the heart has been taken out of the chest, as we've done in this neonatal specimen. This is a heart which was rejected for transplantation, and we then got from a tissue bank in the UK Human Tissue Bank. Now, what's happened over the centuries is the heart's been taken out and stood on the apex like this, and the reasons for that, as you say, are pretty unclear. And that's then given us problems in the way we name the various structures within the heart. What you can see is that it gives rise not only, as Prof said, to the problems in the way we name the coronary arteries, the papillary muscles, but to other structures within the heart as well. So the problems perpetuate themselves the more and the closer we look at things. So what I'm showing you here then is this neonatal heart, and you'll see that with the heart positioned on its apex in this Valentine's fashion, then the right-sided structures, the right ventricle, as you see here, and the left ventricle are very much right and left-sided. And similarly, the atriums, right atrium, and there you see the left atrial appendage there, are very much right and left-sided. The great arteries, which you see quite nicely coming from the ventricular mass, crossing one another, and we're going to emphasize this in the next few sessions, are then positioned such that the pulmonary trunk in this, the heart in this position, is very much anterior to the aorta. Okay, so we have the pulmonary trunk anterior and to the right of the aortic root with the heart in that position. Now, if we turn the heart around in its attitudinally correct position, so you see I flipped it around, I turned it by 45 degrees approximately first of all, so now we're looking at the heart, so we're looking from the head of the patient, and then if we tilt it around, so we're looking from the front, you'll see that the great arteries in particular now have a slightly different arrangement, so very much the pulmonary trunk is sitting on top of the aorta. So it is slightly anterior still. It's still in front of the aorta, but it now is positioned also on top of the aortic root. And I think that's important when you come, particularly when you're looking at echocardiograms, if you're doing, for instance, fetal echo, and you're scanning, you're able to scan the heart in multiple planes, or you're doing MRI. And I think it's important to understand how you shift between the view of the left ventricular outflow tract, for instance, and then move upwards towards the head, and you're getting the pulmonary outflow tract and the pulmonary trunk and the pulmonary valve. So this is as the heart sits in the chest, and I think understanding it in this position helps you understand those sort of echo and MRI planes. So we'll emphasize the normal anatomy, I think, in the next few sessions. Let me just show you then and emphasize to you the position of the coronary arteries, as Prof has said, and then I'll move on to the cast and another heart just finally to illustrate to you the problems that exist when we're naming structures within the heart. So Prof has already mentioned that the coronary arteries here are named effectively incorrectly because, as you see, this is what we call the anterior descending, left anterior descending coronary artery. So there it is, running within the interventricular groove between the right and the left ventricles, and clearly it is in front of the heart in this position. If we tilt it around this way, then you can see that that coronary artery is now running superiorly, and in fact it descends really. It descends towards the apex of the heart, but is certainly very much in a superior position. And then on the other side, we'll emphasize these in a later session, here you see the posterior descending coronary artery there running between the two ventricles. So now this is the left side of the heart, and this is the right side of the heart. And the posterior descending coronary artery is running along this flattened surface of the heart, which sits on the diaphragm. So the heart in its attitudinally correct position, the diaphragm would be where my fingers are. So it's very much an inferior or a diaphragmatic coronary artery. So we need to just be aware, as you say, when we're looking at the coronary arteries, of their true position within the ventricular mass. And I think it's true as I say, of many other structures within the heart. We could carry on, really, and I'm sure we will during these sessions, describing things in attitudinally correct fashion and pointing out the differences. But here you can see, looking in the right atrium of this adult heart, you see quite beautifully this structure, which is the atrial septum. We'll emphasize this in a later session. So we've got the atrial septum here, and you can see the rims of the atrial septum, and there's a lot of interest, of course, in closing small holes in the atrial septum, closing PFOs, etc., by catheter. We need to be aware, really, of how we name the rims of the atrial septum even, because traditionally, again, if we sit the heart on the apex, then this is the superior rim of the atrial septum, and that simply doesn't make sense. Again, so if you're putting the heart in attitudinally correct fashion, then this is the cranial margin, perhaps better called the cranial margin rather than the superior rim, just to avoid confusion. But this is the superior rim. The inferior rim is the rim closest to the inferior carpal vein, and then we have rims towards the AV septum, towards the AV valves, and a rim towards the pulmonary veins, which is more posterior. So, just to emphasize, really, the fact that we need to consider the attitudinally correct names for these structures throughout the heart. Now, this is a cast of a heart, which you'll see many times during this course, and hopefully you'll get a chance to look at a copy next door as well. But really, it shows beautifully the arrangement of the chambers, because as you see, we've cast the right heart structures in blue and the left heart structures in red. And with the heart in attitudinally correct fashion, then you'll be aware that the right heart structures sit very much in front of the left heart structures. We see very little of the apex of the left ventricle just here, and the aorta sitting in the center there. So the right heart structures sit anteriorly. This is where the sternum would be positioned. So if I tilt the heart around a little bit, tilt the cast around a little bit, this would be the position of the sternum. So it's directly in front of the pulmonary outflow tract. Of course, that's important when you're operating and when you've performed surgery on this outflow tract, because it often becomes adherent to the sternum. So the sternum sits immediately in front of that pulmonary outflow tract. This is the diaphragmatic surface of the heart, as we've said. We've then got two important margins. You'll see that the margin towards the front, towards the sternum, is a much sharper angle. I'll show you that in the specimen in a minute, but you'll see that it has quite a sharp angle anteriorly. So this is what we call the acute margin of the heart, and the acute marginal branches of the coronary arteries supply that region. And then on the other side, we have a much shallower angle, an obtuse margin, towards the left side of the heart, and the posterior side of the heart. So this is the obtuse margin of the heart. Diaphragmatic or inferior surface, cranial surface at the top.